voice is breaking, Dr. Paulo.
Sorry?
Your voice is breaking.
Okay. I don't know what to do here. It's the Wi-Fi of the
you can disconnect your audio. You can disconnect your audio, then reconnect.
Okay. Okay. So okay. Is it better now?
Yeah, much better.
Okay. Okay. So if it happens again, that's what I should do, right?
Yeah.
Okay. Yeah, quite here the things are pretty much similar to what they used to be nowadays. So we have back to our regular surgical plans. We don't have any case in Porto in the last 11 days or 12 days.
Oh, lucky you, man. That's good. For us, actually, it's going up. We're going up to about 115 cases for deaths every day now. But like, it's a huge country. So from that aspect, it's not that bad. Where the percentage of people dying have come down to about 1.8% mortality. So which is the lowest in this region. But still, it's there. It's not yet gone away.
Do you had to convert operating rooms to ICUs?
No, it was never this bad. We still, despite the numbers going up, still we have some spaces.
Yeah.
And majority of the people are actually, they've heard about this, that once you go onto a ventilator, the chances of your survival are slim. So many people, even with bad problems, do not come in.
Right.
And they're scared that once they go on the vent. And now with the steroid thing, everybody knows that. So there, people starting the steroids at home, or their physicians are giving them steroids once they get sick or whatever. So it's like we were taking chloroquine. There are some reps who were going around giving chloroquine to doctors who were saying, "You're getting exposed. Take this routinely." So, so all that was funny. I think
better than detergent, right? Better than detergent.
Yeah, I totally agree. Maurizio has an emergency case, so he can't make it today. He's just messaged that he's got stuck with an emergency. Maurizio tried doing this 2 weeks ago, 10 days ago, and at that time there was some problem with his Wi-Fi, and he couldn't fix it. So we couldn't hear him very well, so we had to postpone his talk. And I think today's talk is also postponed because he just called up half an hour ago to say he had to go for an emergency. So we will have only one talk, which is good. Then we get more time to discuss. It is fun for us. Paulo, I would like you to please start.
The future.
Introduce our guest and let's start.
Okay, thank you. So the future of neurosurgery is turning black, right? Okay. So thank you.
Would you like to introduce and let's start?
Yeah. Okay. So let's start. And first, I'd like to thank the Pakistan Society of Neurosurgery and FNS for inviting me. It's really a great pleasure and an honor to join these webinars once again. And it is my privilege to introduce Professor Roger Hartl from New York to this presentation. And we want to with spine surgery, right? No?
Hello?
Block. Hello? Can you hear me?
Yeah.
Okay. So
yes,
so let's start with a foreseen of the future of neurosurgery, right, Roger?
Yeah.
Okay, thank you.
Well, thank you so much for having me at your event today. I'll share my slides. Can you see
Yes.
the first slide?
Yes, we can.
That's great. Well, thank you, Paolo, for the introduction. Thank you, Salman, for organizing the meeting. Pakistan is one of my favorite countries. You know, I think I've been there 3 times. I was actually supposed to be there now in June for another meeting. Unfortunately, we had to postpone that, but it's really one of the most beautiful and hospitable countries. There was a video that went viral last year of a beautiful Pakistani lady walking, you know, showing the landscapes and the cultural heritages in Pakistan, and it was just amazing to see that video. And then going there myself, obviously, I've always felt extremely privileged and welcome. So it's a real honor to be here and to be speaking to you. And I recognize some of the names of the participants here. So I'm a neurosurgeon in New York, and my practice. I'm at Weill Cornell, which is one of the universities here in New York. My practice is primarily degenerative. I had a background in trauma. I did a lot of, as a neurosurgeon, I did a lot of head trauma, head injury, but then really over the last 10, 15 years really specialized in spine surgery, and minimally invasive spine surgery and navigation were always my special interest. And there's obviously always a reason for everything. And, I did a lot of navigation when I was training in neurosurgery. And to me, it always made a lot of sense to try to translate that into spine surgery. And it was a very difficult road initially, but I think, and I'll talk about that over the presentation, I think what we've shown over the last 10 years or so is that navigation really in spine surgery is a very important component, especially if you think about the future. I'm biased because my practice is MIS. So obviously for me, the future of spine surgery incorporates to a large extent MIS. So I'll share that bias with you. But obviously there are many, many more things going on in spine other than MIS and navigation. These are my conflicts. I try to be as objective as I can. Let's talk about spinal future. So I think navigation and robotics are an important component of what we have to deal with as spine surgeons and what we can deal with. I think there's a real benefit of incorporating navigation into your practice, and I'll show you some examples. One term that we coined is total navigation, which essentially entails replacing fluoroscopy completely with 3D navigation. With some of the new navigation technologies that is feasible and possible, I realize that certain areas may not have the technology available right now, but then again, there are certain hotspots, and I know in Pakistan that is true as well, where actually a lot of the technology is completely available, and where some of the technological capabilities that you have may actually exceed a lot of what people have in the rest of the world. Augmented reality is something I'll talk about a little bit. I think we're still very early, but we have to consider that because I think it will make spine surgery safer and improve the workflow for many procedures. What we talk about a lot in Europe and in North America is lateral surgery. There is a movement now towards single stage lateral surgery. So doing anterior A-lift surgery, O-lift, lateral surgery all in one position, plus placement of pedicle screws with or without navigation. There are some surgeons now in Italy, but also in the US proposing prone lateral surgery. I'll have a few slides about that. Deformity correction, obviously, especially with lateral surgery now, with the capability of taking down the ALL, the capability of implanting expandable cages and hyperlordotic cages from a lateral or oblique approach really improves our ability to perform deformity correction with spinal and MIS surgery. And then finally, I want to talk a little bit about endoscopic TLIF. I don't do endoscopic surgery, but I realize that there is a movement towards endoscopic surgery. I don't think it makes a lot of difference for microdiscectomies and so forth, but I think there are some interesting developments when we consider fusion surgery, like an endoscopic TLIF, for example, especially then combined with some of the less invasive anesthetic approaches, ERAS protocols, and awake surgery. So anyway, so that's what I'm going to talk about. And MIS, you know, I look at it in relationship to open traditional surgery. If you plot the complexity of an operation versus the invasiveness, and you start with a very simple operation such as a lumbar disc herniation on the left side, and you plot it against, you go up in terms of the complexity of the procedure, a very complex deformity problem on the right side, you'll see that with traditional open surgery, that curve goes up very quickly. What MIS does is it dampens the curve. And that means, and that is my personal opinion, but I think that data is supporting that. So if you look at simple pathologies, it doesn't really matter if you do it MIS or open that much. Think about a lumbar disc herniation, whether you do a tubular with an endoscope or even with an open microdiscectomy, those patients go home the same day, they do very, very well. The same is true for very complex deformity cases. MIS doesn't really give you a huge benefit there. But the benefit zone for MIS is really then in the in-between zone. And the in-between zone, in my opinion, those are patients who have lumbar spinal stenosis, maybe multi-level stenosis, patients who need a 1 to 4 level fusion. Those you can do with MIS, TLIF, XLIF, LLIF, OLIF, whatever it is. But that's really the benefit for MIS surgery. And that's, however, also the majority, especially in degenerative pathologies, the majority of cases that we do are those benefit, the middle range of spinal pathologies. So, so what's out there in terms of navigation? Now, there's a lot of talk, especially if you go to meetings or you listen to companies. They always try to tell you, oh, it's navigation against robotics, and then there's augmented reality, virtual reality. Nobody really tries to understand how this all kind of comes together. And that's why we put this slide together. If you think about navigation, you got to think about imaging technology, and that starts with fluoroscopy. Then there are fluoro-CTs that allow you to get intraoperative type CT scan type images. That's fluoroscopy based, so a fluoro-CT, so that's like the ZEAM or the O-arm. And then there's a true intraoperative CT scanner. You know, different companies have those available. There's the Arrow and the other true intraoperative CT scanners. They give you 3D images. And then you can use preoperative diagnostic CT scanners that you can load into your imaging, your navigation software in the operating room. So those are the imaging technologies available. On the other hand, there's navigation technology. So that's 2D navigation, and then there's 3D navigation, and then and part of that is robotics, and part of that is augmented reality and virtual reality. So all that goes into navigation technology. And in between, you have the planning software. You know, that software now that's available to help you connect both and plan your surgeries. And this is a very, very exciting area, I think, in spinal surgery that we really haven't entered yet to a full extent. So that's how I look at navigation. So it's not really robotics versus navigation. It's really, it all fits together. And if you understand that, then you can really leverage the benefit of navigation. Now, what we use an intraoperative CT scanner that is connected with the navigation software. So you get a CT scan in the operating room and you directly import that into your navigation software and you can navigate right away. That facilitates the workflow and speeds up the time. Since we've been using that, I used to use a fluoro CT in the OR, which was more cumbersome, but now with an integrated system where you have the imaging and the navigation together as one system, it facilitates the workflow. And that's in doing a lot of cases over the years, I realized that there was no real need for fluoroscopy for the majority of those cases, because once you started navigating, you know, we put in the screws first, and then we realized that with navigation, you can do everything else as well. It helps you with your decompression, placement of the cage, placement of the rod. So you can basically navigate everything. So we call that total navigation. And except for in lateral cases, we pretty much replaced fluoroscopy with navigation. So we use navigation for the skin incision in the very beginning, for the screw placement of the tubular retractor when we do an MIS case, for the decompression, placement of the cage, rod measurement. So obviously you have to be very careful. You got to make sure that while you're doing that, the navigation still remains accurate. So I tape down the patient to the table. I try to really maximize accuracy by using tips and tricks that I can share with you at another point to make sure that the navigation really remains accurate throughout the case. This is a paper we published a few years ago talking about MIS T-lift surgery using total navigation, so completely eliminating fluoroscopy and just navigating an MIS T-lift. And this is how we tape down the patient on the operating room table for an MIS T-lift procedure. That's the CT scanner here. We put the reference array into the iliac crest. I use the iliac crest reference with a 2-pin fixation for navigation up to T12, T11 maybe. It's very accurate for those indications. And then we start using navigation. We get a spin, and we start using navigation right away. We plan the skin incision based on the trajectory for the pedicle screws here. And so we make skin incisions for the MIS T-lift. And now we have, and there are several companies that have these screw systems available. These are pedicle screws that you can navigate. They have an integrated K-wire here. So you don't have to navigate the tip, the K-wire, the screw separately. It's essentially, you navigate one instrument, you insert it through the skin incision into the pedicle, you tap it, and then you can straight, if the bone is, sometimes the bone is very hard, sometimes you still have to tap, but in 80% of cases, you can just kind of insert the pedicle screw through the pedicle. It goes into the bone very easily. So it's a single step pedicle screw placement. And we've been using that for the past 2 years or so. And it really facilitated the workflow and cut down on the time per screw. Now, once the screws are in place, we use navigation for the decompression and for finding the disc and for the cage placement. That's freehand navigation. That's something you can't really do with strictly robotic surgery. But with freehand navigation, you have a pointer and you can go through the tubular retractor, you can go into the spine, and it shows you exactly where you are. And that can be very helpful in patients who have degenerative spondylolisthesis, a very collapsed disc space, or in cases where you want to do a contralateral decompression. You can confirm that with your pedicle probe, with your navigation probe. And then you can use, obviously, navigation for other indications. If you put in iliac screws or S2 iliac screws, you can plan those with navigation, and it just becomes a really, really wonderful tool to do all types of things. So not only for screw placement, but also to find pathology and confirm decompression and so forth. There's another paper we published then a few years ago where we summarized all our cases that we navigated. And again, navigation eliminated fluoroscopy in 3/4 of all cases. And the only cases where we really use fluoroscopy is lateral surgery, because during lateral surgery right now, there's so much manipulation of the spine that the navigation is just not accurate. But that's something we're working on as well. Now, looking into the future, what are other benefits of navigation? Well, wrong side surgery is one of the most expensive problems in spine surgery or brain surgery as well. This is a brain MRI for those of you orthopedic surgeons. So, and the reason why navigation became so popular in brain surgery, yeah, of course, it makes, it shows you where you are, but it really eliminates the potential of doing wrong side brain surgery, which was a huge problem. In the 80s and 90s, there were huge lawsuits, even now. So if you use navigation, by definition, you can't really operate on the wrong side of the brain. And the same is true really in spine surgery. The right level, the wrong side of the surgery. So we should leverage navigation more to really eliminate those mistakes. And we're not doing that because we're only using navigation right now to put in pedicle screws, but it's really a limitation. We should really be using it more and to make surgery safer, to make sure we're at the right level, on the right side. There are software packages now available that allow you to auto-segment the spine. So you get a scan, and then the software tells you automatically the level, it labels the correct level. Companies such as Medtronic, BrainLab, Nuvasive, they're all working on incorporating those types of software packages into spinal surgery. And we're not 100% there yet, but I envision a time where we walk into the operating room, and even for microdiscectomy, you have the MRI scan, you get maybe an X-ray, it merges both, and then your navigation system tells you exactly where the right level is, the right side. So I'm sure that that's going to happen sooner or later. And then obviously surgical planning. This is just an example from a deformity case where you can use software preoperatively to plan your surgery and then translate that into an intraoperative surgical plan. Again, this is at the very beginning. We're not there yet, but that's where I see the future of spinal surgery, where instead of guessing, you really use software to plan, especially deformity cases, and that will be translated intraoperatively into your surgical navigation. I want to say a few words about augmented reality. I guess since we have more time, if anybody has any questions, I'm happy to answer questions. I'll leave that up to Paolo and Salman to decide, or we can do it afterwards. But augmented reality is something that we started working with. You all aware of the goggles that at meetings, maybe you've seen them. There are companies that now advertise the goggles that you wear as a surgeon, and you look at the spine and you can see the bony anatomy, and you can put in pedicle screws percutaneously with goggles. Well, again, that's one way of using navigation, and that's a very exciting way of using navigation. I was more interested in using augmented reality for surgical procedures to facilitate the workflow. Again, not necessarily to put in screws, but to really leverage the advantages of augmented reality to make anatomy easier understandable for the trainee, but also for the expert surgeon in the operating room. An example is the MIS TLIF. Now, this is a brochure that we put together with AO Spine for the MIS curriculum that describes the MIS TLIF procedure step by step. And there are certain landmarks that you use if you do an MIS procedure through a tubular retractor. The first landmark is the inferior edge of the lamina, where you start making your cut to disconnect the inferior articulating process of the facet joint here. So you need the inferior edge of the lamina, and then you have to identify the pars, which is really where you're drilling to, or you can use an osteotome, but those are the two bony landmarks that are sometimes difficult to see, especially if somebody has a hypertrophied facet joint, you're operating through a small tubular retractor. It's very hard sometimes to see the anatomy. The other bony landmarks for an MIS TLIF are the pedicles. You know, this is the lower ipsilateral pedicle, and then the disc space, of course. So those are all the surgical landmarks. If you could see those landmarks right when you put in your tube, and you know exactly where those landmarks are, that would facilitate the workflow and would make your surgery safer. Now, and guess what? You can actually do that with augmented reality. Now, this is a tubular retractor placed over L4-5 on the right side. And here with augmented reality, we marked on the intraoperative CT scan the disc space, the pars, and the inferior edge of the lamina. So you bring in the microscope, and then under the microscope, you know, you see obviously the muscle tissue and a lot of anatomy that you can't really tell immediately what it is. But the augmented reality projects into your view the lamina and the pars and the disc space, so immediately you know kind of where you are and where you have to look for things, rather than with trial and error. And then here in this lower image on the right side, this shows you the L5, the ipsilateral L5 pedicle, the ipsilateral L4 pedicle, and we have removed the facet joint here, and now with the ball tip, I'm palpating the pedicle below. That tells you where the disc space is, and then roughly where the dura is, and so forth. So that's what we're trying to work on right now, to use augmented reality, again, not only to put in screws, but really to facilitate the workflow for MIS TLIF surgery and other even decompression procedures, and also for training and teaching purposes. And this is a MIS TLIF that we did, and again, we project the the pedicle. This patient already had pedicle screws placed. So you can see the pedicle screw here on the right side, the L5, on the right side L4, the pedicle outlined and projected through the microscope. For those of you who look really carefully, you can see there's a small CSF leak here that we had to fix later with a small stitch. So now let's talk a little bit about robotic surgery. There's an incredible push from industry with robotic surgery. But again, I don't think that it's one against the other. I think robotic surgery is great for surgical planning, for placement of pedicle screws and instrumentation. But again, robotic surgery doesn't really allow you to use augmented reality, doesn't allow freehand navigation, but it is certainly very, very important and very helpful for certain types of procedures. And at the end of the day, we really want to combine it. We want to combine robotics, augmented reality, and freehand navigation. It really all has to come together. This is just a paper comparing accuracies of different types of navigation technologies and putting in pedicle screws. So they compared robotic surgery, freehand navigation, the O-arm, which I assume is some type of navigation in this case as well, and fluoroscopy. And using fluoroscopy alone, then the accuracy was much lower. And with all types of navigation, you really improve the accuracy of pedicle screw placement. And those are results that virtually all studies kind of show that navigation makes you more accurate. Now let's move to lateral surgery. I talked a lot about navigation, augmented reality, robotic surgery. What about lateral surgery? I think lateral surgery really, since 2006 or 7, when Pimenta first introduced it, it has really taken off, and the technology has advanced significantly. And I think there's a real benefit to lateral surgery. I want to show you this case. Now we've done lateral surgery now, from the very beginning, and what we've seen is really that instead of doing flipping patients, now we try to do everything in a single stage lateral position. This is a case, a patient who had a previous L4, L5 fusion done somewhere else and developed adjacent segment disease at the level above and the level below, has a moderate deformity, a mismatch of 19 here, not a terrible deformity, but it's a moderate deformity. And this is a great case for lateral surgery, single stage, because these are the pathologies that we can really address very effectively. This is a CT scan that shows you better the adjacent segment disease above and below and the previous fusion. So this is a case that we did in a single stage lateral position. We did a lateral ALIF approach here we use vascular surgeons in North America for the most part. So we have 2 or 3 vascular surgeons. Pretty much all they do is approaches for spine surgery. So they get really, really good at that. So we used the vascular surgeon for the approach, and then we did a lateral, an XLIF approach here for the L3, L4 level, and then put in screws from the back, single stage. That's the vascular surgeon closing up while I start putting in screws with navigation. And this is the reference array for the navigation system. We get an intraoperative CT scan for the pedicle screws. The cages in the front, we still use fluoroscopy because it's just not, in my opinion, it's not accurate enough for navigation, but there are surgeons who use navigation for that as well. So, and then that's the lateral screw placement. Again, once you've done that a few times, it's very, very straightforward. You can do it with fluoroscopy as well. There are a few tips and tricks to make sure that navigation is accurate in a lateral position. But once you're comfortable doing that, it really becomes second nature, and it's very straightforward. And this is just a sequence of images during the surgery, and that's the post-operative result. We got a really nice correction here, and this was all done in a single stage operation without having to flip the patient. Now, surgeons have published their experience with single stage, single position surgery. This is just an example from a few years ago from another group. And the advantage is really that you avoid the flipping the patient. So there's a time component here. So it makes you a little bit faster in the OR. And that's really the main advantage of that type of surgery. Surgeons have also used then a robotic navigation for placement of those pedicle screws. The angle, especially The contralateral side can get very tricky, obviously, because you have to go from below. What I do is usually I rotate the patient away from me as much as I can. Obviously, that patient really needs to be stabilized well. Then I get my intraoperative CT scan, and then you don't have to, then you have a much more favorable angle for that contralateral screw. Now, one of the most challenging problems with lateral surgery, in my opinion, is always the prediction as to, is indirect decompression really going to work for that particular patient? You know, the big advantage of lateral surgery is that we leverage indirect decompression, and you don't have to do direct decompression. So you basically avoid the risks of having to go in there, looking at the nerve root, do a direct decompression. But sometimes there are cases where you're not sure, where you're not sure if lateral decompression alone is really going to be good enough. And in those cases, I will still drop a tube and I will do a decompression. And we did a series of patients now where we did single stage lateral surgery with L-lift or X-lift surgery, pedicle screws, and then we were not sure. We still dropped the tube to do direct decompression, and it turns out that that's very, very feasible in a single stage lateral position. So every once in a while, again, we bring in the microscope, drop a tube, and then after we've done the cage placement, we drop a tube and do a direct lateral position decompression at the same time. And we use navigation for that. This is a case where, again, we dropped the tubular retractor, we did put the cage in, the pedicle screws, and then we dropped the tubular retractor to also get direct decompression in that particular case. This is now through a tubular retractor using navigation. You can see the cage that we placed. So it becomes really much more efficient, the whole procedure. It also lowers your threshold to do a direct decompression if you think that that patient may need it. The other benefit of lateral surgery is deformity correction, and hyperlordotic cages now and ALL release allow you to really leverage that. And this is an algorithm that was just recently published by Praveen Mumanemi and one of my partners, Kai Fu. This is an updated, expanded MISS deformity algorithm. And if you look at this, you'll realize really the majority of deformity cases, and I'm not going to go through this in detail, but the majority of deformity cases can be done partially or completely with MIS techniques, especially looking at ACR, mini open PSOs, expandable cage technology, or hybrid procedures. And only the ones who really have a fixed deformity and require 5, 6, 7, or 10 level fusion, those are the cases that really have to be done with open surgery. So it's really exciting to kind of see how MIS really has evolved. Now I'm almost at the end here, but these are slides from Bill Taylor, who's very involved with ESMIS. He's in San Diego, and they've done a lot of work now with prone lateral surgery. So this patient is in a prone position. They did an open decompression here, as you can see. And then they dropped an invasive retractor here. I think it is an invasive, but some type of lateral retractor, it doesn't matter. And they put in the interbody cage from the side. I'm not sure exactly what the advantage is here, but I guess you can leave the patient in a prone position, which maybe help you with your deformity correction. And then obviously Claudio Lamartina just published his experience in 7 patients with prone lateral surgery, and we'll have to see where that goes. But it seems to me like there's a interest in really doing this type of surgery in the prone position as well, and there may be some advantages. What I've been watching locally, especially here in North America, but also in Asia, is the evolution of MIS T-lift surgery using endoscopic technology and using expandable cage technology. This is a paper from Asia. 7 patients, early experience using MIS T-lift surgery with an expandable titanium cage. They saw favorable results in their patient series. And then obviously Michael Wang, who's really been spearheading awake T-lift surgery with endoscopic technology. He uses a different type of cage. It's a mesh filled with allograft bone, that seems to have good results for the interbody fusion. And he does TLIF surgery awake. I don't know. We'll have to see where that goes. It's certainly interesting. I personally, I think I can't imagine. I mean, if I had that surgery, I wouldn't want to be awake. But some patients seem to, favor that, or maybe older patients. There are a lot of patients, older patients, who are worried about general anesthesia. So that's basically my view of the future of spinal surgery. As you can see, I'm biased towards navigation and MIS. There's obviously a lot of other exciting developments out there, biologics for disc regeneration, disc repair, disc replacement even. For degenerative disorders, there's a lot of interesting development in cancer surgery, metastatic tumor surgery. But these areas here, I picked those because I know a little bit about those, and I incorporated some of them in my own practice, and I can certainly see locally here that this is where we're moving, especially the single stage lateral surgery, navigation, augmented reality, more and more, and endoscopic surgery. So that said, thank you so much. We do every year, we do a big MIS course in New York in December. This year it's going to be virtual, and I invite all of you, if you're interested, check it out, NUCMIS. It's on our Cornell Neurosurgery website, and hopefully we'll see some of you guys there. In the meantime, thanks again, Salman, and thanks, Paul, and everybody else for listening.
Well, thank you very much, Roger. Yes, can you hear me?
Yes, I can hear you.
Okay, thank you very much for this excellent presentation as always, and for showing us a little bit of like the brave new world that is being more and more common. And before starting with the questions from the participants, I would like to start with two questions for you. One is more a technical one. That is the navigation. You told that when you do TLIF, minimal invasive TLIF, you put the screws before, which makes sense because you have less changes because you have your scan, and you put the screws where you didn't touch the spine, right? And I always do on the side of my approach. I always just keep the K-wire to have more space. So apparently this is not an issue for you having the rod and the screws there and putting the cage and the decompression afterwards. That's all.
Yeah, I think that that is a good question, because the concern is that if you put in the screws, that may interfere with your placement of your tubular retractor. I think it depends a little bit on the system that you use. The system I use is a very narrow, the extension sleeves are very narrow and they're mobile, they move out of the way. I used to, when I used K-wires separately, I did the same thing. I would keep the K-wires in on the ipsilateral side and work around the K-wires. The concern then is that you may pull out the K-wires or something, So now that I use the single stage pedicle screws that have an integrated K-wire, so not a separate K-wire. It turns out that the profile of those screws is really so small that it doesn't really interfere, And the trajectory for those screws, if you use navigation, I think that is more lateral. If you use fluoroscopy, I think you're still coming in more straight, so you're closer, to the midline. So with navigation, you come in more from the side, so they're even further out of the way. And then I make a more medial incision for the tubular retractor, and then the tubular retractor really it's very rare that it would interfere with the screws.
Okay, but you do a different incision for the decompression?
Fascial incision, the same skin incision, the same skin incision, but then I make two fascial incisions. One fascial incision, a little bit more lateral, for the screws, and then one more medial for the tubular retractor.
Okay, now I got it. And you put the rod at the beginning or just at the end of the surgery?
At the end, the rod at the very end.
Yeah, because
And
you
I,
can
and I put
compress,
in the
right?
yeah, and I put in the screws first for the reason that you mentioned, because the accuracy is obviously much higher in the beginning, and then as you do your case, you lose a little bit of accuracy. But then once you get to the decompression and to the cage placement, it doesn't matter if it's a millimeter off or 2 millimeter. It doesn't really matter anymore.
Thank you.
Roger,
Thank you very much.
I think brilliant presentation. Really enjoyed it. All the stuff that you've shown was amazing, and it's actually the present that you showed. Some of the future you hinted, but majority of the stuff that you showed is all that you guys are doing over there. It's very nice. My question was, especially for trainees, the important thing is obviously whatever you put in a computer, that's the result you're going to get. So the kind of imaging you get, for example, breathing problems with patients, they're on a ventilator, and when the patient is moving, it's a thoracic spine or something. Or when you're operating, as you said, you're putting in screw and the patient moves a bit, and then you lose all that accuracy, despite doing an intraoperative scan. How much of a problem is that for you?
Yeah, it is not that much of a problem, but I did a case yesterday where I used navigation for far lateral disc, and like I said, I mean, as you become more comfortable, you expand navigation. Like for far lateral disc, I like it because it gives you the anatomy a little bit better. And then that patient, anesthesia had a problem. The patient started moving and everything, and then I had to get another spin because it was inaccurate, So yeah, I mean, but it happens rarely. It really happens rarely, and it's really a function of how you stabilize your patient in the very beginning. So I spend a lot of time literally taping the patient to the table, and then I don't use any mallets. I don't push on the spine. I use I drill. I don't like using osteotomes, and that's for that reason, because I don't want to manipulate the spine, because every time I manipulate something, I lose accuracy.
Yeah.
So I mean, you have to certainly take those things into consideration. I don't use the Jamshidi needle because you have to hammer the Jamshidi needle into the spine. I use a drill. I mean, when I used to use K-wires, I would use a drill, not a Jamshidi needle. Those are like little things that you have to switch around. But if you take those precautions, then I think it's really accurate,
Okay, agree, totally agree. Owner Yaman has joined us. I'm just going to unmute him for his comments. He's joined us from Istanbul.
Oh, good.
You need to unmute yourself, Owner.
Hello,
yes, please.
Hello, Paulo.
Hi, how are you, Owner? Good to see you.
Roger, it was really a fantastic topic, and it's really the future, because I think, especially in the deformity surgeries, we all have to learn this topic, and we have to learn how to put the TLIF cages as minimally invasive there. I think I have to go to Roger's place and to learn how to do the minimal invasive surgery, the deformity surgery there. Thank you so much.
You should definitely come. My fiance is from Istanbul too, so we'll have a nice reunion.
Yeah, thank you so much. It was really a fantastic presentation.
Thank you.
Paulo, there are some questions there. Would you like to read them, or shall we unmute those people?
What do you prefer?
Rupesh, I'm just going to unmute Rupesh. So let's see.
Perfect.
And he can ask his own question. Yes, Rupesh, please.
Thank you, sir. Hello, Dr. Raza. Sir, my question is, I want to know about your opinion on single position PTP, prone transverse fusion, and posterior fixation. I want to know if you have done any such surgeries with any advantages or limitations. If you have, like, how do you avoid lumbar plexus injuries like neuropraxia and all in these cases?
Yeah, I showed a few slides about prone lateral surgery, and that's something that is really being pursued now by a number of surgeons. I personally, I haven't done it because, you know, I think that I'm very happy with lateral surgery, with single stage lateral surgery. But I talk to surgeons who do prone surgery, and what they state as a potential advantage is the amount of deformity correction you get, because that patient is, if that patient is on a Jackson table, you know, you get lordosis by positioning the patient, and maybe that is an advantage of doing these these cases in prone. And then obviously all the work that you have to do in the back, you can do in a more comfortable position that you're used to. You know, the patient is prone. If you have do a PSO, or you have to do some kind of posterior decompression, you can do that in a prone position. So there are certainly advantages to it. My understanding is that one of the disadvantages is that when you put in the cage, you don't get that resistance. If somebody's in in the lateral position, you're working from the top down, and if you insert the cages, the lateral cages, that makes that part a little bit easier. If that patient is in a prone position, you don't get that resistance, and while you're putting in the cage, you move the patient to the other side. So I think that can be a little bit of a concern. I'm sure they'll figure that out. And I don't know, honestly, I'm not sure exactly how if there are any special risks to the lumbar plexus or how they avoid that. You know, it's one of those things that I personally, I would watch and see where it goes. You know, I wouldn't want to be necessarily the first person to do this, because I'm very comfortable with lateral surgery as it is, but there may be certain advantages, the ones that I mentioned.
Okay, we have Kasarika, and I've just unmuted the Kasarika. Would you like to ask your question, please? Kasarika, Larry, are you there? Okay, he's muted himself back. So I think let's read his question for him. So his question was, are there any contraindications of navigation and robotic surgery?
Contraindications for robotic surgery?
Yeah.
Well, I wouldn't say necessarily contraindications, but there are certain cases that are more favorable for robotic surgery or less favorable. I know that robotic surgery is a challenge for lateral screw placement, especially in the lower lumbar spine, because of the awkward position of the patient. I know that I know surgeons do it, but the surgeons who use robotic navigation, they always struggle with the screws that they put in on the contralateral side in the single stage position because of the weird angle. I think depending on the imaging technology that you use, robotic surgery can be a challenge for certain types of deformity cases. If you, for example, if you use preoperative CT scans and then have to match them intraoperatively with fluoroscopy shots, in deformity cases, that can be very challenging. And that's a lot of the robotic surgery initially was really built on the principle of using preoperative CT scans and then trying to match them intraop with x-rays. And that can be a real challenge in significant deformity cases. So I think that the imaging technology is really the limitation here. It's not necessarily the type of navigation. So for deformity cases, it's certainly advantageous to get true intraoperative imaging with an intraoperative CT scanner or with a fluoro CT. But other than that, I don't see, I mean, cervical spine, you know, there's a I think limitation right now. Robotic surgery is primarily for thoracic and lumbar spine. I think cervical spine, it's not that as evolved. The anatomy is smaller, and it's just a more challenging situation for robotic, but also for freehand navigation, you know.
Okay, we have Parvat Kumar. He's from India, and he's got a question for us.
Sure.
Sir, you did. Hello, sir. I'm Dr. Prabhat, sir, from Hyderabad. Sir, in lateral pedicle screw fixation, you are doing, suppose if the patient is the left lateral and you are doing the left-sided screw fixation in the top. What about this right-sided screw fixation? You are turn the patient, or you are by the same position you are doing this?
Yeah, you mean the contralateral?
Yeah.
Yeah, sir. Yeah, contralateral.
Let me see, since we have, let me just see if I can show you maybe show you the slide since we have maybe a little bit of time here. So I'll show you what we did here. Yeah, it is a challenge. This is the slide probably. So now this patient here is in a lateral position. Let me see. Yeah, that's the contralateral screw, right? So this patient here is in a lateral position.
Yeah.
And so the left side is up. The front is here. The vascular surgeon is closing the front. I'm in the back, and I'm putting in now the ipsilateral screw on the left side, right? Now the challenge is going to be, how do you put in the screw below? And what I do, what I find really helpful is that that patient is obviously taped down to the patient, and I use navigation. So what I do is I will rotate the patient away from me as much as I can. Even in this picture, I think that patient is rotated a little bit, but I would rotate the patient even more away from me, and then get the scan for the navigation. And then once you rotate this patient further away, then it's going to be much easier to get that screw in, the contralateral screw, because you're not going to have to go from all that below. You're going to be at a much more favorable angle. But you got to make sure if you use navigation that you get the scan after you rotate the patient. If you get the scan and then rotate the patient, your navigation is going to be off because the whole anatomy is going to shift a little bit.
Yeah.
So you gotta really try to rotate the patient away from you, and then put in the contralateral screws. You know.
Then
That's the
then
key.
you mean to say that you again registered again navigation first?
Well, for the navigation, no. In this case, I would position the patient, rotate the patient away as much as possible, then get the scan, and then put in the screws on both sides. You only get one scan.
Okay, brilliant.
And then yeah.
Okay, Roger, what I wanted to ask you was, if you were to say that, okay, this one thing, if we improve this thing, then we are home and dry. Like, you know, what one thing would you like improved with image guidance or with robotic surgery or with anything for future? If you want to fix one thing that gives you trouble during surgery these days.
Oh, I think it's the accuracy. You know, that you find a way to really make sure that the biggest challenge now is, well, I mean, let's put it that way. I think the one procedure is still where we're not really comfortable using navigation is the placement of the cage, the lateral surgery. And I think that has to do with the fact that when you do lateral surgery, you manipulate the spine a lot. I think if we find a way to put in lateral cages with minimal manipulation of the spine, for example, using expandable cages instead of cages that you mallet in, then that would make navigation much more applicable for lateral surgery. And there are some companies that work on expandable cage technology. And if you have expandable cage technology for lateral surgery, you can eliminate a lot of the manipulation that you have to do during the surgery. So that's one thing. And then the other thing is, to update navigation. For example, you get a scan here. If you had a way to quickly update it, like with fluoroscopy shots, for example, so that you can use 3D navigation, but then you can update it with intraoperative fluoroscopy shots. That would be, and again, that's also something that some companies are working on, but that would really facilitate us, the navigation process.
Okay, that's brilliant.
Let me go back to this point of the expandable cages. Is that all the expandable cages are titanium-based typically, so they have a higher model of elasticity. And the other thing is that you don't have space for grafts inside the cage typically, right? So you put, I presume that you use BMPs and for your fusions, correct?
No, I don't use BMP. I try to avoid it because it's expensive. There's always a concern about side effects and so forth. I use as much autograft as possible for the MIS TLIF cages. I use autograft, and then for lateral surgery, I use commercially available, allograft type materials,
Okay, but so you put them around the cage, basically, right? Not inside.
No, you mean for TLIF or for lateral surgery, or both? For TLIF, I put it around because I use an expandable titanium TLIF cage, and you're right.
Yeah.
You cannot put a lot of bone graft into the cage.
Yeah.
But for the TLIF, you can put so much bone around it that it probably doesn't matter.
Yeah.
For the lateral surgery, I put bone graft into the cage, but the expandable cages for lateral surgery, the ones that I've seen, they all have the possibility. You can backfill them with bone graft.
Yeah.
See,
the other thing you said, you already mentioned about that, that drilling is better than hammering for navigation, but for the screws that you were talking about that have the K wires inside, typically you don't drill, right? You go directly with that.
Yeah, you go directly in. Those screws. I can go back here.
So you don't drill, right?
No, you don't drill. These screws here are basically they have a very aggressive tip. So you just you gentle tap, gentle tap, and then this KY goes into that KY is only a few millimeters. It goes only up to. I mean, you can put it out 25 millimeters, but usually in the beginning you have it at 5 millimeters, and then it gets into the bone, and then you slowly turn the screw with gentle pressure, and once the screw catches the bone, you can retract the K wire.
Okay. Thank you.
Yeah.
The other thing you were talking.
I really enjoyed this. Thank you, Roger. Yeah, yes. Sorry.
No, please.
Go on, Paulo, go on.
No, the last thing I was talking. Sorry?
Go on, sorry.
No, okay. I was also about laterals. I totally changed to the anterior to psoas. Some years ago, I did trans psoas, but then I totally moved to press psoas. What do you think about this?
I think there are different. I think it's totally fine. I think you have to. There are different potential complications. With the straight lateral, the incidence of neurological complications may be higher. With the oblique, the anterior to the psoas approach, potentially there's a higher risk of vascular injury. I think it's really based on your preference and who you work with and how you were trained, and it makes it. There's certain companies that promote different procedures. In my opinion, it doesn't really. I think there's no. It really depends on your comfort level. I like the trans psoas. I've done it many years. I think I do it very safely and very efficiently, and I think that I don't see a reason to really change it. And the only reason to change it potentially would be with the anterior psoas approach. It gives you more exposure down south, and the iliac crest is not as much of a problem. So maybe that's a potential advantage. Again, if I was training today, if I was like 10, 15 years younger, I would probably take a closer look at the oblique. I would probably try to add that to the spectrum of procedures that I do. But you gotta look at the big picture. I think that for me right now, it doesn't make sense to really switch what I'm doing, and I'm very happy with that. But there are certain pros and cons to both.
Yeah. No, I think the main reason why I changed was because it was boring for me having neuromonitoring for the lumbar plexus. So I don't use neuromonitoring anymore. So that's the reason for me.
See, I'm worried about the vessels. You know, for me, the worst case scenario is a blood vessel injury, and therefore I'm very comfortable with the monitoring. I don't see any.
Roger, and your results with monitoring for lateral, Paminta now talks about that the results are that bad that he would not do this lateral case kind of thing.
Who's that? Who says that?
I'm talking about Paminta.
Oh.
Yeah. So he was saying that 30% of patients with weakness or dysesthesia is following surgery from lateral approach. So your experience is not the same.
No, I mean, Louis, I know Louis very well. We've been doing our MIS courses together for the last 13 years.
Yeah.
And Louis now is interested in the prone lateral surgery. And listen, I mean, he's the one, he's been promoting lateral surgery for 10 years. Yeah. And I don't think that he's going to go away from that. I mean, and he's working now with a different company. There are a lot of different, there are a lot of different lateral surgery. There's a clear learning curve. I mean, my incidence of nerve irritation or nerve injury in the beginning obviously was much higher than now. Now it's really rare. Once you become comfortable with it, I agree, you need monitoring, but it becomes a very, very straightforward procedure, even at L4, L5. And so I'm totally comfortable. But I'm saying that if I was training today, I would certainly take a close look at anterior psoas, especially because of 5-1 and some of the L4-5 cases where direct lateral is not an option.
Yeah. Okay, that's brilliant. Roger, is it possible that you can unshare your screen?
Sure.
So that we can show the future presentations that are coming up, and then we have a group photograph before we wrap up, and a last comment from both of you. Yeah. So we'll just see what we have coming up in next few days. Ahmad, can you please show us? Thank you. So we have. This is neurotrauma, and we have ICP monitoring guidelines from Randy from Harborview, and we have cranioplasty timings and complications guidelines from Corrado, and Navida Shrif and Ehsan Bari would be moderators in this. And next. And we have Roton neuroanatomy course. Now we are on module 3. So this is session 1, and we have first 6 cranial nerves. We have Miguel Arez and Pablo Gonzalez from Spain who will be taking us through. And with them, we have Chandrasekhar Dopujari with Hassan Sayed and Azam from US. And we go on to next. And as we were talking about this endoscopy, so our 2 friends from Korea will be talking about transforaminal disc, and Lim will be talking about multifunction role of endoscopy, basically doing endoscopic MIS TLIFs. And we would have Nicole Epiv and Oscar joining us as moderators. So this is our next 4 talks. Can we, we have another talk coming, go on, sorry. We have more, so Franco Cervedi and Randy are the moderators in this. There's neurotrauma guidelines for lower middle income countries, and cranial neuromodulation from Tariq Imtiaz from Saudi.
Wow, you got a nice program there.
Yeah, this is for next 10 days. This is wonderful. Can you unshare this, please? Thank you. And we would have last comments from Roger, and then Paolo, and then we wrap up. Yes, Roger.
Yeah, so I mean, again, thank you so much for having me, and I'm really honored by your invitation, of course. Say hi to Randy next week. He's one of my, he got me into neurosurgery in the first place many years ago. And we had a great time in Peshawar last year together, as you know.
Yeah.
So, I think that the future of spine surgery, I think at the end of the day, at the end of the day, you got to think about what's the safest for your patients. It's not important to do the sexiest procedure or the most complicated procedure. At the end of the day, it's really, you got to do what you're comfortable with in the environment where you practice. And so that has to have priority. And that's the reason why, I'm very skeptical when new technologies come out, and you have to really be, there are certain things, if you're very comfortable with them, maybe you want to be at the forefront, if you really know a lot about it and you're really actively involved. But I think you got to be very, very skeptical, because a lot of the new technologies are sometimes pushed by companies or individuals, and you really want to make sure that the patient safety and the success of your surgical practice is number one priority.
Okay, please, can you all unmute? Just open up your video so that we can take a group photograph. Please just open up all your videos. I need a smile from all of you. Please share your screen. Thank you. Thank you, Jonas. We have so many people from interesting places. Okay, can we all smile? Imad, are we done? Okay, it's wonderful seeing you all like this. Paolo, your last comments and we close.
Okay, thank you. So again, just to thank someone for the kind invitation. It's been a pleasure being with Roger and Honor here as well. I really think this is also taught us different things about the future of neurosurgery, and this is one of the things as well, that we can communicate long distances, we can share expertise, we can have access from very remote parts of this world, and this is I think neurosurgeons have always been in the upfront of technologies and innovation, and I think it's brilliant the way that that neurosurgeons have adapted to new ways of sharing expertise and learning and teaching. This has been great, and definitely we'll keep on that, and we'll keep communicating, and we are still all learning in this new era.
Yes, brilliant. The one thing we had forgotten is that we have WFNS Spine Committee has a deformity course from 5 to 7 tomorrow, and after that we have the neurotrauma committee having their trauma thing. So unfortunately, I'll be sitting for 4 hours, but I'm moderating the WFNS Spine Committee session, which is deformity, and we have 6 wonderful speakers from 6 different countries. Owner is one of them who's going to be joining us, so we're looking forward to that. So all of you are most welcome. It's 5 o'clock for deformity and 7 o'clock for neurotrauma. So everybody is most welcome. And Roger, again, I'm grateful. Thank you for giving us time. It was wonderful seeing you again, but hopefully we'll see you live soon.
Thank you so much, everyone. Bye-bye.
Thank you.
Okay.
Thank you.